I want to welcome everybody today to the WASHA webinar series. Thank you so much for joining us. I'm Ingrid Nielsen, Chair of the WASHA Education Committee, and I will be facilitating the webinar today along with Karen Vogel, who will be assisting students. And hopefully at the right of your screen you can see the chat box or the question box, and you can communicate with us. We are especially delighted to welcome our speaker, Dr. Alexandra deGroot. She will be presenting on the invisible disability that often creeps up on us, untreated hearing loss in adults. Most people consider hearing loss just a normal part of aging and often wait much longer than necessary to address hearing loss, and often at the recommendation of their doctors. Unfortunately, waiting longer can lead to significant health consequences, and Dr. deGroot is going to help us understand the magnitude of the problem, what you can do about it, whether you're an advocate or if you're advocating for somebody else with hearing loss. So she'll start by reviewing adult onset hearing loss, wealth of information to share strategies on coping with hearing loss, avoiding hearing aid scams, finding a good audiologist, and much, much more. And she will leave you with a list of excellent advocacy and support resources. I did want to let anybody know who has connection issues that if you have any questions, you can contact GoToWebinar customer support at 1-877-582-7011. They recommend trying to re-enter as your first option because you have a unique registration link. I'd also like to let you know that we're recording this talk, so all participants are muted, and we'll wait for questions and answers till the end of the webinar, but you can submit your questions at any point during the webinar, and you can put them in the chat box or the question box, and the chat box is probably the easiest. I'd also want you to know that we are planning to send a PDF version of the speaker slides, so you will get those, and we will post the recorded webinar on our website in about a week or so. And we are also in the process of evaluating the possibility of making this webinar closed captioned. So at this point, I want to introduce our speaker. Dr. deGroot received a BA in speech pathology and completed a doctorate in audiology from the University of Washington. She was the recipient of the UW Carol Minor Award for Outstanding Clinical Achievement. She is a practicing audiologist using up-to-date and evidence-based options with a focus in audiological assessments, hearing aids, and oral rehab. She also owns Hearing Ally, where she consults with both individuals and professionals. But beyond complex diagnostics, she considers her most important role that of being a hearing advocate, where she's passionate about communication issues and how individuals with hearing loss can continue to thrive and improve their quality of life. I know you're going to enjoy hearing Dr. deGroot. I'm going to pass it off to you. Welcome.
Well, thank you so much, Ingrid, for that wonderful introduction. I really, really appreciate being here with all of you. And I want to just first say thank you for all the work that each of you do as health advocates, whether that was in former careers and or what you're doing now, helping people really get access to the care they need to lead the great life they were born to lead, and or whether you're a family member of someone with hearing loss or you yourself have hearing loss. We congratulate you for coming and taking the reins to make some changes in this area for yourself or other people. So I also want to mention, write down questions as we go, since we're saving them for the end. I don't want you to forget, something that was burning. And then also I'm going to have a number of links to outside resources, because we're not going to be able to go into great depth on some things that you guys might want to go into today. So I'll give you resources for that if I can't cover everything. Okay, well, let's just dive right in here. So today's talk is based on research and evidence-based methods, of course, as well as just my personal clinical experience and my life experience with people with hearing loss and just communicating in general. And that's important to note. We all have communication issues even when we have normal hearing. It's part of the equation. So just real quick, my experience, where that life and clinical experience comes from, as Ingrid mentioned, I did do my degree, doctoral degree, and my residency at the University of Washington Medical Center. But I've also worked in private practice ear, nose, and throat clinics for 6 years, and I've done outreach in Vietnam and El Salvador, and worked with people of all with hearing aids and cochlear implants and other devices. So I have a pretty broad background in terms of audiology, but I primarily work with adults. And then through Hearing Ally, I do provide continuing education for healthcare providers on specific topics. So my first course will be on tinnitus, and that's something that you can sign up for on my website. And that's me with one of my cochlear implant patients over in Bellevue. All right, so I like to just show kind of this first model of, what we think of with aging. Aging, of course, causes, all these other things, or is associated with all these other things: cognitive decline, dementia, increased fall risk, all these lovely things we have to look forward to. And of course, hearing loss. As Ingrid mentioned, we all kind of accept and know that hearing loss is part of natural aging for most people. What I want to bring in today is that there's actually more than one model about what mediates those factors. Leaving a hearing loss can actually also is very strongly correlated to increased risk of dementia, cognitive decline, falling, as well as depression and social isolation. And we're going to go into this a little bit more. These correlations are even when we're correcting for the person's age. So you think, oh, well, we're getting older, we get more hearing loss, so then of course it's correlated with all these other things. They were able to do these studies and show that even when age was taken out of the equation, we still saw an increased risk of these things. And again, I want to highlight, this is correlation, not causation per se. And that's an important thing to keep in mind. We don't know necessarily all the mechanisms here, but we do know that treating hearing loss can really mediate some of these things. Okay, so nice bright orange to wake you up there. So we're going to go over what is hearing loss, the cost of leaving it untreated or undertreated. That's a good point there. Excuse me. What you can do with your clients or your family, and the role of someone like myself, an audiologist or ear, nose, and throat physician, and knowing how to refer your clients to professionals that you trust. Okay, so quick review here. I'm going to show a diagram on the next slide. There are two main types of hearing loss. That's conductive hearing loss and sensory neural hearing loss. Excuse me, I had to take a drink there. And the third type is mixed hearing loss. So it's really just a combination of the first two. I'm going to go to the diagram here so I can show you more clearly the difference between those top two. So if you can track my mouse here, I'm going to put a little highlighter on here. A conductive hearing loss resides in the outer or the middle ear. So that's this whole section right here. So if something gets blocked in this area, like scar tissue on the eardrum or earwax, that would cause a conductive hearing loss. We are not going to talk about that today. Okay. And sensory neural hearing loss resides in this cochlea right here, or the auditory nerve, this section that I'm highlighting right now. So this is where we're seeing age-related sensory neural hearing loss, or losses caused by a noise-induced damage. So if you're a visual person, that helps, but let's go back to my normal cursor there. So in a little bit more detail here, presbycusis or age-related loss usually has a gradual onset. It's usually symmetric, so it's pretty equal between both ears. It resides primarily in the high-frequency portion of our hearing range. It's usually primarily cochlear in nature. And what I mean by that is when I showed you that diagram, there was the cochlea, the inner ear, and the nerve, those two sections. In a age-related hearing loss, we're usually talking just about the cochlea. And that's important to know kind of more down the road, but a lot of times people will say nerve hearing loss, and that's not 100% accurate. Just wanted to let you know kind of the details there. Some other sources of this type of hearing loss, like I said, can be a noise-related loss, but you can also have things like toxicity from some chemotherapy, platinum-based chemotherapeutic agents like cisplatin. When we do have other types of loss, we might see a different configuration on the hearing test. We might see a big difference between the ears. And those are definitely cases we want to make sure we have a medical evaluation or medical management. It might be something we can prevent the decline of more effectively. And we don't want to assume that all hearing loss when we're older is because we're getting older. It might be from something else that needs to be treated, including a tumor. Which is not fun to talk about. So this is just a screenshot from one of the websites I'm going to show a link to at the end. It's called cochlea.org. It starts in French, so you actually have to go to the upper right-hand corner and select English. There is a student tab as well as a general public tab. This site I like. It's got a lot of interactive little videos about mechanisms of the ear, so if you want to kind of get geeky and learn about that, that is a good resource. So let's look at some of the underlying causes a little bit more, just so you can kind of get a sense of what might be driving this for someone. So vascular conditions can cause different types of hearing loss, autoimmune and viral origins, like I said, noise damage, and I should mention noise damage is cumulative over your life. So, you know, it kind of is interesting. You think, well, I ask patients, well, have you had a noise exposure? Were you in the military or did you listen to loud music? And they say, oh yeah, well, that was a long time ago. Well, the truth is your ears are the same as they were when you were 20. So it's a cumulative effect. Whatever you did when you were 20 or 30 is happening now in your ear, and what you're doing now can affect your hearing in the future. So wear hearing protection is the message there. A blow to the head, ototoxicity, like I mentioned, so different kinds of chemicals. That link right there is for a kind of clunky web page, but for healthcare providers, it's kind of nice. You can look through every single herb, supplement, or medication that lists an ear-related side effect. So that does include dizziness. So you're going to see a lot on there that are not related to hearing, but you can look at that to see if something's impacting your hearing, or things like ringing in the ears. And then of course age, and I want to put on here that age-related, when I think of age-related, I think of, you know, normal healthy aging when we see mitochondrial decline. We also see when we age that we have greater risk of things like vascular conditions. So diabetes or hypertension, all those things can seem to also get worse as we age, and they can compound the effects of the age-related hearing loss. I can answer some more detailed questions about these things later on, but I'm going to move ahead here. Oh, yeah, and again, these do not regenerate on their own right now. I mean, there's lots of research going on, but as of right now, these causes create permanent losses. So hearing loss is really common, but it's invisible, so we often don't know how common it is. We don't see it on a day-to-day basis. 60% of Americans over the age of 60 has a hearing loss. And to add to that, 20% of those over the age of 12 have a hearing loss. So it's even more common in younger individuals than you might think. One of the reasons it's invisible is because the person themselves may not know that they have trouble hearing. It may also look like other things. And so, and then there's people who don't then get their hearing treated, so we don't see them wearing hearing aids. We don't often hear people saying they're having trouble or they have hearing loss because they may try and hide it. And then, of course, even when you do wear hearing aids, they're getting more and more invisible these days. So very, very common. So let's go through that a little bit more. Hearing loss is invisible, like I said, to the individual very often, as well as healthcare providers and employers. So the reason for this is because of that slow, insidious onset, which is most common. You know, humans are so great at adapting. We naturally adjust to these things. We see studies, actually, it's a little scary, that parts of the brain that are dedicated to processing sound and hearing will actually convert to better processing visual information, which, you know, makes sense, but it's only been more recently really shown on imaging studies. So we start to use visual cues more. We start to compensate by filling in with context cues. So we might not notice that this is creating that much of a problem, and we don't know what we're missing. You don't know you're missing the beeping sound in the elevator. You don't know you're not hearing your blinker. So it makes sense. The other part about this that's important to note is that when you have a hearing loss and you don't know it, or even if you do, other people might notice it on some level and just not know it's a hearing loss. They might think that it's something else, like cognitive decline, or that, you know, you're just not paying attention, you're not listening. It can look very much like these things. You know, you ask someone how they're doing and they answer you with a totally inappropriate answer for that question. Someone says thank you when you leave a store and you don't respond. So it's important to know, I think, for healthcare providers and patients, that even if you don't notice your hearing loss or you don't think other people notice it, something's going on there, and usually people are going to make up a story about what's going on, and it's probably not going to be their first guess that it's a hearing loss. And then, you know, a lot of times people do have a sense that something's wrong, but as I'm sure many of you know, in healthcare, denial is a very powerful thing. And it can make it very easy to avoid until we have, you know, someone like a health advocate or a healthcare provider or a spouse just really getting on someone's case to do something about it. And then last, you know, people do think this is normal aging, which it is, but it doesn't mean that nothing can be done. So we're going to go into that. I also want to just mention here, as far as healthcare providers go, the typical scenario is you might say, oh, I screen for hearing loss with my patients. I say, do you have a hearing loss? And they say no. Unfortunately, as we're getting to here, that's not an effective screening for hearing loss. People are going to say no even when they do have something going on. So here are some of the things that are associated with an untreated hearing loss in adults. We've got reduced income, which obviously affects people who are in their working years. You can see how that might impact, you know, at a meeting. If you answer the wrong question, if you seem like you're ignoring things, you might not get that. You might not get that promotion. You might not be a part of a team that wants to work with you. Can really impact, have a big ripple effect in the workplace. If you're not saying anything, if you're not asking for accommodations and not letting people know what you need. Increased risk of fall later in life. So you might have hearing loss at age 50, and I'm not saying, you know, if you don't get hearing aids now, you're going to start falling next year. I'm saying if you don't make sure that you're getting, you know, stimulating blood flow into that region of the ear and staying aware of your environment, it's going to increase the risk of falling much later in life. Increased risk of dementia. This is very interesting. With more hearing loss, we're seeing greater risk. So with a mild hearing loss, we're seeing around a 2-fold increased risk of dementia. Moderate is about a 3-fold, and up to severe and profound, we see a 5-fold increased risk of dementia. And that is all-cause dementia, all types. Decreased brain volume and function. So the size as well as cognitive ability, so those seem like they would of course be related, but they are two separate things. We're seeing a 30 to 40% increase in decline. Now, we all see a decline typically as we age, but this is a 30 to 40% increase on top of normal aging. And that is beyond just the auditory regions. So we're not just saying, oh, the part of the brain that is responsible for hearing shrinks. We're talking about the whole thing. And then, the last one I think is something that we tend to see the most, especially as things progress a lot more. We see our grandparents or our parents really start to isolate themselves a lot more. They might avoid social activities that they used to do. They might go to those events, but then they're completely withdrawn. You have a family gathering and they're sitting in the chair in the corner. And it makes sense. We're humans. We connect to other people. That's, it brings us joy. It gets us connected to music and life. And when you're disconnected from that, even in a mild, moderate way, even if it's not all the time that you feel the impact, it can have a very strong ripple effect. And again, all of these things are even when corrected for aging. We see these impacts. So this all seems kind of grim. So what can you guys do? The first thing that doesn't necessarily seem like what would make the most sense is actually you guys modeling effective communication strategies. So I'm not saying that you need to be an audiologist or you need to be a professional speaker or something. What I'm saying here is that it's very, very helpful for you to understand the types of communication strategies that really help people with hearing loss, with or without hearing aids, just hear you better. We're going to go over those in detail, but you modeling those not only shows the person that they can relax and they can be confident that they're going to follow along and be engaged in the appointment with you, but they can potentially pick up on what they need to hear better, and they might start doing those things themselves, or their family members may start taking up those practices themselves and really just forming a better foundation of communication. The next is the more obvious one, referring for quality medical and audiologic care, and being prepared to address the issues related to getting hearing aids, like the cost. Again, we're going to go over that. And then counseling the patients on importance of treating hearing loss and promoting the follow-through and prevention. So, like I said, a lot of doctors don't know about this. So that's the work I'm trying to do, is really educating healthcare providers. But you may be the only person in their healthcare team or in their family that knows how important this is, and everyone else around them may be saying, oh, you can just wait until this is a really big problem. You can just tell me when you have enough of a hard time, and that's when you should do something. That's not true with hearing loss. A lot of healthcare providers will look at this as kind of like a hip replacement. They say, well, we can't do anything until it's really bad, so just do your best until then and let me know. Hearing loss is not like that. So it's important for you to be the one that knows that and encourage the patient. So let's get back here. So I don't know, I just put this photo in here because we so often see people when they're not doing well, and when they're sick, and when they've had so many other things kind of accumulating as they've gotten older. Our hearing seems like, well, this person has cancer, they've got problems with their feet, they've got diabetes. How are we going to start talking about hearing aids at this point? Our happiness and our connection to other people and our ability to stay active and engaged and understand what our doctors are saying, these things are so immensely vital. This is a really important piece of the puzzle. So let's go through some of those communication strategies, and I'm happy to talk about this more with specific examples once you guys have questions. But first, face people. This is kind of common courtesy. You wouldn't look away from someone normally when you're talking to them, but we get kind of casual with our families often, or if there's multiple people in a group. So you want to make sure that you're facing the person you're addressing, or the person with hearing loss. They use visual cues, so you don't want to cover your mouth. You don't want to be chewing gum or something like that. Not that I would imagine you'd be doing that in an appointment, but it's important. It just distracts them from the information they're using. You don't want to yell. I mean, people might say what and speak up, and we kind of go from like 0 to 60 a lot of times. So you don't want to distort your voice in the way that we do with yelling. You want to project from your diaphragm. So this is something that takes practice. I'm not going to expect everyone to start doing this tomorrow, but you want to really feel where the power in your lungs and your voice are coming from, which is actually in your solar plexus, and that can help you really project and not strain your vocal cords, and not distort the shape of your mouth, and also not have a tone that seems like you're yelling. It can be quite upsetting for people. The third one is actually one of the ones I think is the most important. I do have a video on this on my blog that goes over it for about 10 minutes, so we'll just kind of touch on this here. But you want to articulate and slow down, but of course you don't want to overdo that. So articulating and slowing down is important for a number of reasons. Obviously, it gives more clear cues about what the sounds are that you're making. You're giving them clear visual cues that you're saying an F versus a TH, which are very easy to mix up with an age-related loss, or other sounds like C or P. You can see those on the mouth. Slowing down is really helpful because, especially in background noise, because our brains, when we have hearing loss, we're trying to fill in these gaps, and if we can slow down, we can give the person more time to kind of put those pieces together. As we get older, we're also going to have some issues with how the signal is timing in the brain. So what I mean by that is kind of like, we have like a jazz band, an orchestra of signals going up to the brain, and it's great, and we can think it's, sounds great when it's all in time, but as we get older, that timing can get off, and it can sound like the band is a little offbeat, and it makes it harder to know what song is being played or what word is being said. And by slowing down, I want to encourage you, if you slow down a lot, sometimes people can think this is more related to you thinking that they're cognitively slow. So you want to be really careful about how this is interpreted by the patient. When someone asks you to repeat, you go ahead and repeat, but if they're asking you over and over again, you probably want to rephrase. So try a different word, try a different order of words that can kind of get the person out of a loop of what they think you're saying. You want to reduce background noise when you can. So a lot of times we can't control the environment, but if there's a fan on, you can move to another room, turn the fan down. You shouldn't have a conversation in the kitchen with the dishwasher running. If there's a TV on in the waiting room of a doctor's office, I think it's completely appropriate to ask the front desk to turn that down. Or you can, try to move to a quieter area. Obviously, get closer to the person. This is more kind of in a family situation. I see people say all the time, well, my husband got these hearing aids, but they don't work. He still can't hear me at home. And I say, well, where are you talking to him from? They say, oh, well, I call him from the kitchen, and he's in the living room with the TV on, not facing me, and the dishwasher's running. We can't, with hearing loss, even with hearing aids, we can't necessarily overcome distance. We can't yell from other rooms a lot of the time. And then, it seems obvious, but a lot of times we don't do this. We don't ask the person what's most helpful for them. Everybody is very unique, and they might not have this typical hearing loss. They might have a different kind. So it's helpful to ask them what's working for them with you, so that you can continue to do things that work for them. Okay, and then what do audiologists do? People like me. So we diagnose and treat hearing loss and balance disorders, but we're also educating the patient about all of this information so that they can prevent further decline. They can make sure that they're getting appropriate follow-up, and we're going to refer them for a medical evaluation when they see us. So if you send them directly to an audiologist, a good audiologist should be able to look at the test and say, your ears are not symmetrical, or you look like you have something going on that could be operated on or surgically mediated. I want to make sure you get to a good ear, nose, and throat position. So you don't have to worry about that medical referral unless you want to directly refer to the ENT first. it's good to know we're talking about audiologists here. We can get into this a little bit more with questions, but hearing aid dispensers or individuals, technicians that might be testing hearing in a primary care office or something, a medical assistant, they should know when to refer for things, but they have much less training, so they're not necessarily going to know the intricacies of different medical conditions. And I would not rely on a hearing test from Costco and the person who did the hearing test to get an appropriate referral for this person if they do need medical care. Then we also counsel patients and families on all those communication strategies, as well as relationship skills, self-advocacy, and overall just managing how frustrating a hearing loss can be. Now, all those things in there you might not really think about when you think about what an audiologist might do, but when you have this stressor on a relationship, this hearing loss is stressing communication, it reveals oftentimes a lot of underlying issues with a person's relating skills. So if someone's just really not a social person, or they might not have a lot of social context cues, or they're not a great listener, the hearing loss is going to highlight that, and it's going to exacerbate that. So a hearing aid's not going to solve the problem by itself. We have to work on these other things in conjunction with that. Same goes for the other person who might not have hearing loss. If they're being extremely demanding, or they're expecting the person with hearing loss to just be able to hear them and them to do all the work, that's not going to work either. It's a two-way street, and we need to work with both people to help each other out. And self-advocacy is really important. Someone with hearing loss, it's usually taken them quite a bit to get to my office in the first place. They're not usually very excited about getting hearing aids or telling someone they have trouble hearing, but we know that it's vitally important in their success when they're able to, make sure that they have come to the meeting early so they can get a seat in the front row so they can hear the speaker, or that they've told people in advance that they're going to need special technology to hear as best as they can, or they're going to need a caption service before they come. They know how to troubleshoot their devices. They don't feel like they're helpless when the battery dies or it gets clogged with wax. They need to be able to do all these things so that they are in control of all those factors. And to be able to say, hey, I need you to face me. They need to know the things that help them so that they can direct people to do those things for them, because people they don't know this stuff. We aren't really taught these things in school as healthcare providers or just as people talking. And then managing discomfort and frustration. People come in, obviously they have issues with their relationships. They're often depressed from things that are going on. And it's frustrating to not be understood and constantly say what and then give up. It's frustrating to feel like maybe you can't afford all of the technology that would help you make you hear better. So we work with all of that. And then the technical side is, we're really programming little mini computers, little devices that need to be tuned for a prescription. We need to work with the person's perception of what they're hearing and what they actually need to hear the best, and counsel that person to transition them into utilizing these devices as best as they possibly can, and understanding that they have to wear them consistently. We might think you just get hearing aids and you wear them when you need them, but it's not exactly how it works. So we have a lot of technical counseling and technical awareness that we need to have about hearing aids and other technology, like captioned telephones and smartphone apps and things like that. So an audiologist is who you're going to want to refer people to. We can give you some more resources on my website too about how to find a good audiologist, but generally you're going to be looking for someone with an AuD behind their name. That means Doctorate of Audiology. Some audiologists have a master's degree, and that's just because the degree changed, I think, about 12 or 15 years ago, and they're just as experienced. It's just a different time for the degree. Someone who could do a hearing test and fit hearing aids but is not an audiologist would be a hearing aid dispenser, and they're not, or a hearing instrument specialist, and they may be wonderful healthcare providers. We need more of them because there's not enough audiologists, but unfortunately there are a lot of dispensers that are not necessarily as informed or set up to help people get all the care they need. Okay. Now, what you can do is to help set expectations for clients about this process. Medicare does not cover hearing aids, unfortunately, but some other secondary insurance might. So if the person is retired Boeing, or if they were a veteran, they can usually get pretty good coverage. There are affordable alternatives. So there's a smartphone app called Ear Machine. EARMACHINE. You can download that for free, I believe. It's not perfect, but you basically can use a smartphone as the microphone, and then the person plugs in headphones, and you can manipulate the volume getting into those headphones so that you don't have to yell as much. You can get the volume that the person needs right to both ears. Amplified phones you can purchase. You can also get free captioned telephones from the state. You need to have someone like an audiologist sign off on that to get a person a phone that types as the other person's talking, so they can read along. And there's other kinds of devices like pocket talkers, which is similar to that Ear Machine app where the person wears headphones. And there are personal sound amplifiers now that are on the market. You can buy an ear level device that kind of looks like a Bluetooth device for about $300. And these may be very good options for someone with a mild loss, or someone who really needs something but they can't afford a hearing aid. That'll get them stimulation to that ear that'll really show them the value of something like that. So it's not necessarily all bad, but it's helpful to work with a professional who kind of knows which ones to work with. And stressing the importance of those communication skills. Hearing aids, again, do not cure hearing loss. They are, half the equation. They're very, very important. We need to stimulate that nerve. We need to get that sound into the brain, but it's not going to fix every situation, and it's not going to fix someone speaking who's mumbling or has a very soft voice, or when there's a lot of background noise. We really need to rely on other things. So when the patient understands that going into it, they're much more likely to have better success with their hearing aids. And then, of course, you can send a patient to an audiologist to start, and not maybe a big box store like a Costco. If sending someone to a Costco for a free hearing test is going to just get them to do it because they're going to Costco anyway to get their groceries, great, get them to do it, get it done so that they know they have something going on. But if you can get the person to just get a hearing test at an audiologist's office, that's going to be covered by Medicare, and it doesn't hurt. There's no requirement to get hearing aids. It's all just informative. And that's also kind of like the test run for you to determine if working with that audiologist is the person you want to work with for the next 5 to 7 years with the hearing aids. You want to work with someone who meshes well with the patient and is someone who's going to be counseling them. This is not just a technician position, so you want to find good people. And then again, I want to highlight that doctors may not know the importance of this, so it's really important for you to keep tabs on this, especially when you're working with a patient who's falling a lot, or a patient who has had early diagnosis of dementia or cognitive decline. So quick review here. I wanted to make sure we leave time for your questions. Leaving a hearing loss untreated can have other obvious serious impacts that we would never think of. So like I said, fall risk, cognitive decline, dementia, depression, and reduced income. Age-related loss can be effectively treated. So this is not the admitting of the final domino in the aging process. This is not like this awful thing that we just do when things get really bad. This is something we can actually do much sooner. People that are in their 50s and 40s have hearing loss. This is something we can do something about and make it so that the person actually gets a lot more benefit from hearing aids and a lot more practice with these communication skills if we can do something earlier. The longer and longer we wait to get hearing aids, the harder it is to transition into using them. I didn't touch on this a lot, but I want to explain that people with hearing loss, it's good to kind of empathize with where they've been. They've been missing these sounds for a long time. So we put hearing aids on them, and all of a sudden everything's very harsh and sharp, and things are dinging and noisy, and it takes a lot to get used to. So if we wait a really long time until we have a lot more hearing loss, it can just make it so that it's intolerable. That's when we see patients who say that they put their hearing aids in a drawer or they returned them, even though we know they would really benefit from them. They haven't had the time to get adjusted, and it's very challenging on their system to get adjusted if we wait a long time. And if you're not sure where that sweet spot is, if the person's ready or not, that you don't have to worry about that. That's the job of the audiologist, and to talk with the patient about how it's impacting them. And then last, but of course not least, you have a very, very important role. Very rarely do I see a patient come in on their own. It is because a spouse or a other family member or friend has told them enough is enough, that you need to do something. Unfortunately, not very often, their healthcare providers are not sending them to us. More often than not, their healthcare providers are telling them to wait. So your role is extremely important but it's also extremely important in terms of, like I said, modeling effective communication and really being that person that they can trust, that they're going to understand and is going to listen to them. So I would love to hear your questions. It looks like we have a couple to start here, so let's get those out. I'll give you a second here to type in your questions. And then I'll show you some of those links there that you can utilize. In the middle there, that's that cochlea.org. That's the website I showed before. Vestibular.org will go into balance questions. The NIH website gives a nice overview about hearing loss. LynnResearch.org, that Lynn, Dr. Frank Lynn, he is a researcher out of Johns Hopkins University, and he's got a ton of great long-term studies that really look at all of these connections. And then I like to try and synthesize these things in a little bit more of a digestible, not so researchy way, more real-world clinical way on my blog. So you're welcome to check out my blog. I'll be putting more video content up soon. And there's all sorts of things in there about how to find a good audiologist, why hearing aids cost so much, and all that on there. So feel free to check it out. All right, time for questions.
Well, thank you so much, Dr. deGroot. That was very informative, and I appreciate the compelling reasons to address hearing loss, and early intervention really makes a difference. And I have to say that I would like to encourage everybody to check out the Hearing Ally website because there's just wonderful resources on there. Whether you're a professional, you can get your research links, whether you're a patient, whether you're an advocate. And I have looked at a few of your videos that show you how to do some of these communication techniques, which I think, Ali, you did a good job of describing that it's about communication, but it's also about relationships, and this affects a lot of different things. So let's look at the questions that are coming in. And the first question is, can we get a copy of the slides? Definitely. We will send you a PDF version. You will get that. And also you're going to get the recording as a link as well, so that you can rehear anything that Ali had to say today. And I had a question come into me from an advocate saying that her experience with hearing aids from the Veterans Administration are not necessarily the best quality, and that there are many complaints with them. So do you have any comments about that?
Great question. Yes, so let's unpack that a little bit. So actually the hearing aids, the actual devices that people, in my experience, are given from the VA are extremely high quality. So they do not have a limit on how high tech they can get with people. So they'll give them very high quality brands that are internationally recognized, top selling brands, good companies, and the devices themselves are high level technology. Usually the audiologists are very well trained technically, so they should be able to be doing all the appropriate settings of prescription and all that. The issue that I see occur with the VA has more to do with continuity of care which is not just related to audiology, but you might come in and see one audiologist to get the hearing aids, and then 2 weeks later for your follow-up, it'll be a different audiologist who may not be as comfortable with that particular brand or wouldn't have chosen that particular hearing aid for that person. So you're getting a little conflict there. The appointments, I think, tend to be pretty demanding on the staff. They don't have enough staff, and so you're going to end up with people being rushed through things more. They may not be counseled as effectively to be in terms of realistic expectations and knowing how to use their devices. So I think it's not so much a question of the actual devices themselves, but all that other stuff I was talking about. Effective management of frustration, self-advocacy, communication. There's a kind of a point I didn't mention before that highlights this, is that, out of all the people who have hearing loss in the US, we only see about, 15 to 20% of them actually getting hearing aids or keeping hearing aids. And you would think that that's associated to price as a main factor. But when we look at places like the UK, where those devices are provided at no cost, we're still seeing a very similar rate of acceptance, so around 20%. And I bring this in related to the VA because technically the hearing aids are provided at no charge, but we're not necessarily seeing those people continue to wear the devices or do well with them in all situations, and that has to do with all those other factors. It's not just price. It has to do with how the person has been trained to use the devices, their expectations, and how long they've waited to get hearing aids, and how much their family and other members of their community are supporting them. So I hope that answers the question. Yeah, okay, that's great. So I should just preface this with the average person waits about 7 years, 7 to 10 years from when they actually had an onset of an aidable hearing loss to getting hearing aids. So it's typical to wait about that much. In response to your question, I'm kind of thinking more of the person who maybe has waited like 15 years. They might be in their late 70s or their 80s is what I'm getting from your question. And so when we see that, the person usually has moderate, severe, profound loss. They've already kind of gotten into a lot of habits as far as people don't expect them to be listening. They don't expect themselves to be listening. So you put hearing aids on these people, and I'll talk about what they're actually hearing, but in terms of what you see, you may not very initially see that they seem like they're hearing that much better because they're not necessarily attuned into listening yet. They may not be super excited about listening. So that's the first thing you're going to see. It might not change that much in that way. The way it's going to change a lot for the person is that they're usually extremely irritated. So I try and set the hearing aids for this particular group of people a little bit softer than they need to start, and I let them know it's got to get louder over time, but right now we're going to set it a little softer. We're going to give you time to transition into hearing all these new sounds, and I tell them they pretty much have to force themselves to wear them for the goal is at least 8 hours a day. So you're going to see this person fatigue to listening. They might only be able to wear their hearing aids for 4 hours throughout the day. They might want to take breaks. They're going to be irritated by what they perceive as loud sounds, so plates clinking, even low humming noises in the background like a dishwasher. The car is going to sound like a rattle trap. The toilet's going to sound like Niagara Falls. Someone who's used to having to project to talk to that person is probably going to still want to continue to project, and then that other person's going to feel like they're yelling. So those are the types of things that we'll often see initially, but even with someone who's in their 80s, if they can get those hearing aids in consistently, we know they're not clogged with wax, and we know that they're getting in the ear properly, we do see them transition to adapt to those things usually over time. But we usually, a lot of times, can't get them up to their full prescription because they just can't tolerate that volume, so they're never going to be able to get access to all that sound information that would be most beneficial.
Thank you. Um, I'll just encourage anybody who has additional questions to go ahead and submit those into the question box. And I had a few other questions that came in, and one of them was, did you talk about any ways of getting a hearing aid at a lower cost? Are there any options for that?
Yep, great. I did not talk about that. So there are in the Seattle area and nationally, there are different organizations that provide lower cost hearing aids in a number of ways. There is a hearing aid company called Starkey, and they have a foundation called the Starkey Foundation. You can apply to get hearing aids from this organization. I do believe it is income dependent, so there's some paperwork there where you have to prove that you're lower income. But they do provide new hearing aids. They're very, very basic hearing aids, and you can only get them from providers that have agreed to provide their services at a lower cost. So you're not going to be able to just go to any audiologist to do that, but that's a program that might be helpful. There's also organizations like the Lions Hearing Aid Bank or the Lions Foundation. You normally see them doing things like providing glasses and vision care, but they also will provide refurbished hearing aids in some cases, and that does also require an application where you prove that you are of a lower income. So that's one option. The other option for someone who might not qualify for income like that is if you go to an audiologist and you say, hey, I can't afford these hearing aids that you're selling, the only hearing aids I can afford is going to Costco, and I really don't want to have to go there because I didn't like the person at my Costco or for whatever reason, I would ask the audiologist if they have, a particularly low cost device. So they may not show that to people typically because the really low technology hearing aids may not sound as good depending on the environment you're in, and they don't want to set you up with a device like that and lead you to believe that that's going to sound great all the time. But if it's the only thing that you have access to, it sounds great. It sounds way better than nothing. So I would encourage you to just ask if there's potentially a value model that you could have access to. So for example, at the clinic I work at, our value models are $1,500 for one, to give you an idea of that being the cheap one. And that should come with things like batteries for a certain period of time. It should come with warranties from the manufacturer. It should come with a certain amount of visits from the audiologist. So at our practice, that includes visits for the life of the hearing aid. So when you look at prices and you look at getting lower cost, you want to look at all the things that are included in that price, because it's usually not just the device. If you go to a place where it's really cheap, you're usually just getting the device, and then you have to factor in all of the costs later, like batteries and maintenance and warranties. So if that kind of helps paint the picture on pricing. I also, on my website, I do have a pretty long blog post about hearing aid cost and things like that, getting cheaper things. But the audiologist may also be able to provide some assistive listening devices, like I mentioned, like an amplified phone or that app or some other non-hearing aid devices that would be more in the under $400 range.
And just a quick comment about the cost of batteries. That's another question that comes in.
So batteries generally cost about $1 a battery, and depending on the type of hearing aid you have and how much you wear it, it's going to last maybe about a battery a week. So if you've got 2 hearing aids at a battery a week, you're talking about $100 a year. But if you buy them at a place like Costco, you can usually get them for about 70 cents or 75 cents. So that's a big savings. And again, you want to look at when you buy hearing aids, they should probably include some batteries. At our office, we include batteries for the life of the devices. So you want to factor that in. And there are some hearing aids that do have rechargeable batteries.
And we have another question that's asking, when a person has tinnitus, how does wearing a hearing aid impact that?
Oh, wonderful question. I'm putting up a free course on my, sorry to keep referencing that, but there's just so much information here that I want to make sure I answer your question. I'm putting up a free course on tinnitus on my website in a couple weeks. But the reason that, so someone with tinnitus most likely has a hearing loss, just as a reference. 90% of people with tinnitus will also have a hearing loss. So in the case of tinnitus caused by hearing loss and not like something like jaw tension, and that hearing loss being aidable with a hearing aid, then 70% of those people are going to see an improvement in their tinnitus. Not necessarily a resolving of the tinnitus completely, but a significant improvement when they're wearing the hearing aids. So not when they're not wearing them, like when you take them off to go to bed. So the reason that this helps is because of the actual cause of the tinnitus. So tinnitus is not actually caused by the ear itself. It starts there, but it's actually caused by a response the brain is having to a lack of input. It's more complex than that, but when we give the brain more input, then with the hearing aids, we give it stimulation where you have hearing loss. We're actually giving that part of the nerve in the brain something to do. So it doesn't have to make up the sound anymore. It actually has a job to do. It masks out that noise that our brain is generating. So that is why hearing aids work for so many people. If it doesn't work for you, you should make sure that you get a device that has a tinnitus masker built into it. It should be no extra charge. And if you go to a place like Costco, this feature is not likely going to be included in their devices. So if you have tinnitus, you want to make sure you mention that.
Thank you. We have one final question, and then we'll just make some closing remarks. And that is, what is the expected service life for a digital hearing aid?
Great. So the general answer is 5 to 7 years, and that is not because the hearing aids explode or something at that point. It's very much like why you end up getting a new phone. It becomes much more expensive as the hearing aid gets older to service it. So at 5 years, the FDA no longer requires the manufacturer to keep parts. They still do, but they're just going to charge you more to repair it. And you're also not going to be able to get as long of a warranty on that device after you repair it. So you might only be able to get 6 months instead of a year. So we get to the point where the person's paying $500 to repair one device, and then 9 months later, it's breaking again because of wear and tear. So it becomes a better decision to use that money to buy new hearing aids that not only have new technology, but they've got a new 2-3 year warranty on them, and they can potentially adapt to new needs that the person has had at that point. 5 to 7 years, a lot can happen. So.
Okay, thank you. That was incredibly informative. And if you want to just close out with anything, and then we'll just leave them with some web addresses, and also everybody will get a full copy of your slides. So all of the resources and links that are on there, everybody will get a copy of that. So if you have a few closing comments, that would be great.
Sure, yeah. You know, the thing that stands out to me the most, because I think it's just different from what you're going to hear when you start Googling things or talking to people about hearing aids, is that I really want to highlight how important it is for you to empower your clients and your family members to help themselves in this area, and for you to push them. And I don't mean nag and force, because someone, you know, obviously we know that especially more stubborn people are going to just resist more when you push them. But what I mean is hold for these people that, you know, you're there to help them connect with the world around them. You have resources available for them. There's something they can do, and that their hearing loss is potentially impacting them and their family in ways that they can't see. And so I would encourage them to just try hearing aids if they've been recommended as an option for them. They can always return the devices. They have a 30-day trial period, so it does not hurt to try, aside from the effort of going in there and doing the whole thing, just to see how it can really impact them, because they have to have that experience for themselves. So.
Well, thank you so much, and thank you to Karen for monitoring our questions for us today. And our as we close out here, we would love to get your feedback. We're going to send you a brief survey via email shortly after this webinar. And as we develop this webinar series, we really like to hear from you what went well and what might not have, and also just ideas on other webinars you'd like to hear. Also, if you're new to WASHA, please visit our website at washa.org, as you see on the screen here. There, we have just recently removed the passwords on our prior webinars, and they continue to be very timely, relevant topics. So please take a look at that. If you have any questions, comments, or want to email us about anything or become a member, we'd love to hear from you, and you can email us at info@washa.org. And again, thank you for attending today. We appreciate your support of our webinar series, and I feel like I learned a tremendous amount of practical information. So you'll be hearing from us in approximately a week with all of the post-webinar materials. So have a great day. Thank you so much.
Thank you.